Welcome to iCubed, episode 34. Yeah, episode 34 already. Well, we have a very special episode this time. This will be a December episode. It'll be the last one of the year, and I'm going to end it on a great note. I have two guests this month. I have Dr. Jonathan Graff, with whom you've become familiar because he's been helping with multiple episodes in the past. So welcome back, Dr. Graff. Nice to see you again.
Thank you.
And then I have an extra special guest. I know I say I have special guests every month, but I have an extra special guest this month. Now, those of you who followed me or watched this since the beginning or all along the way, you know I've been an ER doctor forever, right? I graduated my residency in 1992. Ooh. Don't calculate how old I am. Okay, so I would not be exaggerating too much if I said that due to this educator, iconic, legendary educator, so much of my clinical practice has been from him. So I am so super excited to have Dr. James Roberts join us on the iCubed this month. Hi, Dr. Roberts.
You're too kind. Now, you can't exaggerate like that. People are going to expect too much.
I am not exaggerating. Thank you so much, Jim. I'm so grateful that you are so willing to come on an episode of iCubed. Now, I picked this case. It is a very, very special case, and I'm going to have Jonathan Graff tell it because it was his patient. Why don't you go ahead and present the case?
You bet. Thanks, Alice. So it was a 66-year-old male who was brought in by EMS for an acute amitriptyline ingestion. He reportedly had told his roommate that at some time prior he had ingested the amitriptyline, and so it was his roommate who called EMS. Apparently he had taken 100 milligram tablets.
Wow.
And that was about 4 o'clock is what they reported. When EMS arrived, the patient was a bit groggy at the home, but was able to talk with them and actually help get on the gurney. En route, however, he became less responsive, and when he arrived to RED, the patient had a GCS of 5 and a non-rebreather on, and so we had to make preparations for intubation and IV access.
Right.
So interestingly, I was able to intubate without any RSI meds. The verbal orders were given at the time to get the sodium bicarbonate started with that history of the TCA ingestion, and we got an EKG.
Right.
Well, you're very fortunate to know what he took because these are very potent medicines, high mortality rate. A lot of them die on the way to the hospital before they get to the hospital, and they come on very quickly. In 20 or 30 minutes, particularly the big overdose, start to get symptomatic, and they can die very, very quickly. So you got to really be on top of them.
I was working alongside Jonathan that day. I was kind of just doing my thing. And then suddenly I hear the charge nurse go, Dr. Graff, stat to room 31. And I look in the monitor and the guy's in V-TAC.
Yeah, so this wasn't good. They were having trouble getting an IV in at the time. So still hadn't gotten any bicarb. So was able to get in a central line and start bicarb pushes and drip.
This is right after the defibrillation. So this is the EKG, the first EKG right after the defibrillation.
Classic tricyclic overdose EKG, widened QRS, prolonged QT, fast, and you also got to consider hyperkalemia whenever you see a wide QRS like this. But you knew what was going on here, so if you didn't know, this is a little fast for hyperkalemia, but always keep that in the back of your mind when you see this.
Right.
We also called the cardiac alert, talked to the cardiologist. As Dr. Roberts notes, potassium was an issue. We actually got a point of care potassium. I think it was 6, a little high. But that inferior lead, we didn't want to overlook, is he having an ischemic event also in addition to that?
Lead 3 looks like an acute MI and AVF. I can see how you worry about that, but these tricyclics, they screw up the cardiogram so much that it's very difficult. Even sometimes tell V-TAC from just a sinus tachycardia with a wide QRS. Cardiologists don't see them like this very often, and their experience with them is sometimes very nil.
Right.
Yeah. So this is an ER case for sure. Sometimes the cardiologists think that probably the safest thing to give for any arrhythmia is procainamide. And that can be deadly in this case because it has exactly the same toxicity as the tricyclic. So you might get a cardiology resident not very familiar with this. He sees this. Well, I'm not exactly sure what it is, but it's safe to give him procainamide.
Oh, wow.
And, that's a death knell.
We got a blood gas, obviously, the very first one on the left there, when he was stabilized.
The acidosis is very characteristic, when you get acidotic, you increase almost double the free tricyclic, the toxic part of the drug.
Wow.
And oftentimes when you'll get an acidosis after a seizure, and then it gets down to 6.8 or 6.9, and that's when the patient dies because they've doubled the amount of free tricyclics just from becoming acidotic, and that's what does them in. That's why it's so important to get them alkalotics. Shoot for at least 7.5, and that'll increase the binding, and it's really the only real intervention that makes a whole lot of difference. 6 hours are by far the most critical in these cases. If they live for the first 6 or 8 hours, they're probably going to do okay. They can get ARDS, but they usually don't decompensate. And again, the bicarb should still be running on these cases, probably for 8 to 10 hours, at least until the QRS narrows down to below 100 milliseconds. Talk about how to give the bicarb. I think most doctors know how to do this, but if you want to alkalize somebody, you give them rather quickly 3 amps of sodium bicarb. Then you put 3 amps of sodium bicarb into a liter of D5W, and that'll give you the sodium content of normal saline. And run that about 250 mLs an hour in order to keep the bicarb going in.
So for every episode of iCubed, I do try to focus our learning because we are all ADD. There's too much stuff in every single patient to really talk about. We can go on forever. But in this case, we're going to start with learning focus number 1, which will be tricyclic antidepressant overdoses. So I'm going to go through just some really kind of fun facts and just to drill things down. This drug, I don't know who invented this drug. It is an incredibly powerful and multifaceted drug. But anyway, it was used extensively from the 1950s to the 1980s. It actually, over the past couple of decades, has been supplanted by the SSRIs for first line for therapy for depression. The TCAs, however, are still being used for chronic pain, depression, IBS, peripheral neuropathy, and that's what we really need to know about TCA overdoses because they're still lurking around. What it primarily does in terms of how it works for depression is inhibits presynaptic norepinephrine and serotonin uptake.
Each of them have a little bit of a different toxicity. Amitriptyline is very toxic. Protoline is one that almost always causes seizures in a big overdose. They all can cause seizures. They block the GABA receptors in the brain. So if you don't have any GABA, you can seize.
Yeah, great. That's
very, very, very common. When I was a resident in the early days of my career, you see 2 or 3 a week of a big medical center. So very, very a large number come in very sick or basically died in the ambulance. Once they die, it's almost impossible to resuscitate them. Yeah. It's not as though it's you can just do CPR and they're going to come back. If they die from the cardiac toxicity, they're basically can't be resuscitated.
Right. So Jonathan and I are a slightly different generation of ER doctors than you are, Jim.
You have it easy now. You don't have any tricyclics around. All you got is little cocaine and amphetamines. Those are easy.
Right. Tricyclic antidepressants are really complicated medications. And so I wanted to just, if we can, go through some fun facts, I guess, about tricyclics. They are rapidly absorbed from the GI tract. Their maximum plasma concentration occurs very quickly, within about 2 to 8 hours or so. It's a very, very lipophilic drug. Therefore, that means it's a large volume of distribution, and it's difficult to dialyze these types of drugs out of a patient when they have a large volume distribution and lipophilic. The drug is primarily metabolized by the liver with pharmacologically active metabolites. The half-life of these drugs, the TCAs, some of them are shorter than others. They range from 7 to 58 hours. And then because of one of the side effects of TCAs, which is slow gut motility, there's actually delayed absorption and you have delayed toxicity. There's 7 clinically relevant receptor actions that I just want to highlight. So then the first thing it does, TCAs inhibits the fast and sodium channel in the Purkinje system in the myocardium. And what it does then, it decreases the conduction velocity, it increases the duration of repolarization, it prolongs absolute refractory periods, and all of that action leads to the cardiac toxicity and the dysrhythmias you all see so frequently in the tricyclic overdoses.
The decreasing in the conductivity is what causes the prolonged QTC interval.
Then the second action it does is it is also a potassium channel blocker. And so what it does then prolongs the QTC. Number 3, tricyclic antidepressants, it blocks the serotonin and the norepinephrine, and therefore you get hypertension during the overdose initially, and then you follow by hypotension. Then number 4 action, tricyclic antidepressants, is a strong muscarinic acetylcholine receptor blocker. So that leads to an anticholinergic toxidrome, right? It leads to sedation, delirium, leads to being flushed, it leads to being hyperthermic, like my patient I talked about, dilated pupils, slow gut motility, and urinary retention. All of that is in the anticholinergic toxidrome.
You know, Alice, just incidentally, he was distended. His abdomen was distended when he came in, and we intubated him. We did put down an OG tube and did lavage, despite making the histories there, and we got a lot of, pill paste out.
Emptying is pretty much lost its popularity. The problem with these things, if he's not intubated, he can be talking to you and 10 minutes later can have a seizure. So you got to be really careful about gastric emptying in these. I rarely do it anymore. Even if you have them intubated, it doesn't protect their lungs for some reason. We did a study of TCAs versus other overdoses that had their stomach flushed, and the TCAs had a much higher incidence of aspiration pneumonia. The tube doesn't block it totally, so I would say very carefully. Even putting the charcoal down, you aspirate a bunch of charcoal in your lungs, not good. Never been proven to decrease morbidity and mortality. Charcoal or gastric emptying.
Oh, interesting. That's great. So the anticholinergic syndrome, hot as a hair, red as a beet, blind as a bat, dry as a bone, full as a flask, and mad as a hatter. That's all the qualities of anticholinergic syndrome.
In the old days, people, when they saw a lot of anticholinergic symptoms, would be tempted to give them physostigmine. And that's where physostigmine kind of got its bad reputation because they were given to people with tricyclics and they'd have a cardiac arrest right afterwards. And that led some of the toxicologists say, never give any physostigmine with one of these muscarinic clones because it becomes more toxic. But physostigmine is good for pure anticholinergic toxicity. But there's so much more with the tricyclics. You got to just put up with the anticholinergic symptoms.
So going on, the alpha adrenergic blockade causes hypotension, causes reflex tachycardia.
We also had, I know you're a few things here, but we had this patient was very hypotensive. So when he came in, pressure's down to the 60s, 50s even, and we did start pressors, started some neosynephrine, and then went from there.
Yeah, they have alpha blockade, so a lot of people would use dopamine for the first vasopressor, but which releases norepinephrine from the presynapse. It doesn't work for the hypotension. You have to give them a direct alpha agonist. Norepinephrine or neosynephrine are the only ones that really would increase the blood pressure. So those are the ones you have to use.
And then tricyclics also cause H1 block, is an antihistamine and causes H1 blockade, and that causes mental status changes such as somnolence and confusion, delirium, and hallucinations, sort of like an Benadryl overdose. That's just a very classic of Benadryl overdoses. And then the last thing that I just want to mention is tricyclic antidepressants is a GABA A receptor blocker, and that will lead to seizures. And Jim mentioned increased frequency of seizures in the meprotoline overdoses.
Yeah, as far as seizures go, when you have an agitated patient, which they often are, as becoming more toxic, you got to give them some benzodiazepines. They're safe. You need to give enough. Sometimes it'll stop the seizures, but load them up with some Valium or lorazepam when they're really pulling out their IVs and trying to get off the stretcher, and it's just totally out of its CNS wise. Calm them down, because that, of course, increases the fever, increases rhabdo, and increases the pulse rate. So you try to sedate these people. That one's almost always going to be intubated, but you can give a fair amount of a benzo without causing a problem. Don't let these guys sit there and be tied down because they're agitated.
So then, EKG findings in TCA cardiotoxicity. These are very common. The QRS is greater than 100 milliseconds. The EQRS morphology is very strange and very abnormal. The R wave in the AVR is greater than 3 millimeter, as you see there. The R to S ratio in the AVR is greater than 0.7. And then sometimes there is a Brugada-like pattern in the TCA overdose patients' EKG, such as that. So then we talked about this patient's first post-arrest EKG, and we mentioned the different EKG changes. For instance, right there, the QRS is...
It's even hard to measure that QRS because you're not sure where it starts and where it ends.
So the QRS is greater than 100 milliseconds there. Then the R wave morphology is just very bizarre. The R wave in AVR is greater than 3 millimeters. And then the R to S ratio in AVR is greater than 0.7. In this patient, this is the second EKG after the initial ROSC on this patient. And it's still, Jonathan, what did you think of that second EKG after initial ROSC?
It wasn't as satisfying as it is with the hyperkalemia. It didn't resolve as quickly or as nicely as I like to see or I'm used to seeing with the hyperkalemia.
You're very fortunate that you were able to resuscitate this guy. A lot of times it looks like it's VTAC, and you shock them. Doesn't seem to do much. But usually once they have a cardiac arrest, they're done for, because they'll get more acidotic, which means there's more free TCAs. Are you sure he was in VTAC when you saw him?
It certainly was a wide complex tachydysrhythmia, as you can see there.
This is when I was getting involved, because I'm hearing that the charge nurse calling Dr. Graff stat to the trauma room where the patient was. So I looked on the screen, and this is actually what I saw.
The lower one is very suspicious for VTAC. The upper one is not VTAC. It's just a sinus tach with a wide QRS, which sometimes cause people to consider an antiarrhythmic or something of that nature. The bottom one, I don't know, it sure looks like a shockable rhythm. Was there a major change when you shocked him?
Right, so after that is when Dr. Graff got this EKG. And when we looked at the second one, it really didn't change a whole lot, right? Like you were saying, that it's not as satisfactory, not as satisfying as if you had treated hyper-K. So the second post-cardiac arrest EKG looked like this.
I think if I saw that when he was still on bicarbonate, I would have suggested a little 3% sodium chloride.
You bolus that 100 milliliters at a 3%, or do you infuse it over?
We'll give it over maybe 3 or 4 minutes. And you can actually repeat it again the second time. Most doctors have no experience with it or don't use it.
Right.
And nurses can't find it when you're looking for it. So, the other treatment here is interlipid, which 20 years ago they didn't have any interlipid, but it's becoming a sort of a standard in really sick lipophilic overdoses. And Tricyclic's classic one, there's per case reports of given intralipid, which is something you give people to feed them when they can't eat. It's a milky substance, and oftentimes rapidly changes the situation. Give them, the anesthesiologist first used it when they had bupivacaine overdoses, and they would actually resuscitate people from cardiac arrest when they gave them intralipid. It's white, looks like milk, and what you do is you give them 100 cc's over about a minute, then you wait a few minutes and give them another 100 cc's, and then you run the rest of it in over an hour. And what it does, because it's a lipid, it will suck up all the lipophilic substances. And calcium channel blockers, beta blockers, stuff that they have a lot of problems with really reversing. And it's safe to give. The only problem is that once you give it, you can't look at the labs for 6 or 8 hours. So you want to get, before you give intralipid, you want to get some blood so you can look at the potassium and the sodium and those sorts of things. But fairly safe. I've never heard any problems with it, and it works remarkably in some cases. Still, not a whole lot of double-blind studies with it, but mostly just case reports of it. But I say any sick patient who's going down the tubes and you think it's a drug overdose, I think it's safe to give them intralipid.
One last thing here. There was a case report about Brugada electrographic pattern due to a tricyclic antidepressant overdose. I just, again, want to highlight the possibility of Brugada EKG pattern on a tricyclic overdose. The top EKG is the patient EKG after 5 hours of treatment for a TCA overdose, as compared to the presenting EKG with the tricyclic overdose. Next, learning focus number 2 is very quick. Just emergency department management of a TCA overdose that Dr. Graff did fabulously. For me, I've always thought tricyclic overdose was a clinical diagnosis, and you have to start acting right away and do not wait till confirmation, because it's so deadly and you could be really caught behind the 8-ball. And so I make a clinical diagnosis based on history or exam or EKG, the patient's neurologic, cardiac systems, and the clinical presentation of an anticholinergic toxidrome. Then in terms of the diagnostic evaluation, you want to get your EKG, and we've talked about the 5 different abnormalities on the EKG. And then you go right away and treat the patient because they're so critically ill. And like this patient, Dr. Graff went ahead and just intubated the gentleman. And then we mentioned about circulation. The patient was very hypotensive, even right after ROSC. And so fluids were started, pressors were started, phenylephrine. Then in terms of the EKG abnormalities, you go ahead and start the bicarb, give the push, and then the bicarb drip, as Jim had mentioned. In terms of gastric decontamination, Dr. Graff's patient, he did go ahead and try to lavage his stomach because the ingestion was just before coming in. And in this little rapid review, talks about administering charcoal within 2 hours of ingestion.
And this patient was intubated when he got the gastric emptying, right?
Yes.
Yeah. So I wouldn't attempt it in a patient who's not intubated, even though they look like they're doing well, because it can progress so rapidly. And then I got a stomach full of charcoal, and all of a sudden they'll have a seizure and they'll aspirate it. Now you got a lot of trouble.
I think that's a great warning. That's really, really good. And then if the patient seizes, it's a death knell, apparently, but treat it aggressively with benzodiazepines and treat agitation with benzodiazepines. Very aggressive.
I would treat the agitation very quickly without any hesitation because they can progress to seizures fairly quickly. And again, increase rhabdo, increase fear, increase heart rate when they're down. So these are not the patients you have to restrain with restraints instead of putting them out with drugs.
So, well, Jim, thank you so much for participating. Any words of wisdom?
Yeah, really enjoy hearing that perspective that you have, Jim.
When I was a resident and the first 5 or 6 years I was attending, it was a common everyday overdose. And everybody was very familiar with it, always very scared about it. And he's not the patient that you say, "I'll be there in a minute." Go right in there, follow the paramedics into the room with the patient like that, and get them on that EKG and sedate them up. And the bicarb is very important to give.
All right. Well, thank you so much, Jim. I really, really appreciate all the pearls. Even though I've practiced medicine for a long while, I appreciate learning even more. So I appreciate the pearls.
From an old guy, huh?
You're not more than 50, right? I mean, no, come on. And Jonathan, thank you so much. As always, you're always so willing to come on and help me with my screencast. So I appreciate you coming on for this special episode.
It's great. It's nice to be able to learn from Dr. Roberts.
Yeah, absolutely.
Pleasure to be here. Thanks for the invitation.
Well, thanks, Jim. All right, everybody. Thank you so much for for joining us this month. I have had such a great time talking with both Jim Roberts and Jonathan Graff. I hope that you are having a great December. I hope to see you guys at a conference this coming year, and I appreciate your support of my screencast, and we'll see you later. Bye, Jim. Bye, Jonathan.
Bye.
Take care.